This is Kyle, the DMG America. I want to tell you, these people have really been helpful to us in our workshops. We appreciate it very, very much. Thank you. Like the material.
Yeah.
Thank you.
Thanks.
I would strongly suggest that you get that wrench, that easy reach wrench from South Dental Supply, because when you're taking this out of the mouth, especially if you're trying to unscrew the posterior screws, it's a godsend. You know, my hands aren't that big, but I have a hard time getting back there a lot of times, getting the patients to crank open stuff. Stephen's not here right now, but oh, there you are. I'm going to guess the wrench is what, 700?
It's cheaper than that.
500?
Yeah, something like that.
About 500. Yeah, I bought one, and you can auto-plate it. I bought one, and then, you know, once you start doing a number of implant cases, you got implant patients back to back. So I had to buy two. So it's a very worthwhile expenditure. Once again, before we take the impression, we would make an X-ray like this to confirm that the impression coatings are completely sealed. It probably doesn't matter whether you make the impression before you strut or after you strut, but I wait until after. There's a good picture of some of the beginning impression material being injected underneath the struts. So, just as you're looking at yours, I want to make sure that I can visualize those pins before we start unscrewing. I would suggest either using rigid and light or heavy and light. The rigid is a little harder to get through the gun, but the more rigid the impression material, the better. But heavy has become my workhorse. It's because it's a little easier, more user-friendly for the assistant. Okay.
I'll put you down for two.
Yeah,
And
three.
we'll repeat what we looked at earlier today. Here we are with that same impression. Syringing around the struts. And digging it away. Okay, so when you're ready, go ahead and unscrew all of your screws, your pins, and remove your impression. Once again, you can see this. Notice I've got a 2x2 back in the back behind the impression tray to catch anything. Then you can ship your impression to your lab or have to pick it up if you're in town. You know, I work with labs across the country, so I'm shipping these across the country, even in the hot summertime, and everything gets fine. It's pretty much impervious to heat. If you like to do some lab work yourself, then you pour the bottle yourself, and I do that sometimes. Back in. I use dice. I'm used to using this. I walk the paper out, water out, and I mix it with spatulated in the back of the it's easier for me to just say, pour it all in one stone instead of decide. I keep buff stone and I keep some white down. These are just these are straight. And these are the analogs. So the true multi but looks like this. But the flat part is the same.
No, you're good. You're good. Thank you, though.
If it's angled, straight. Oh yeah, well, it's slot. You can rotate it with internal text. Rotate it. Depending on what type of implant. External text, you can actually rotate 12 foot size. Half a hexagon. If perchance you are pouring a bottle, you would want to use a soft tissue material first.
Do you have some
That
instruments?
you syringe in and around the abutment analogs in your impression. Zermac, Z-E-R-M-A-C-K, makes a real good soft tissue material, gingival simulation material. But if you do this yourself, remember that the simulation material is chemically the same as your impression, and it'll stick to each other. They will stick to each other. So you simply lubricate your impression where you're going to inject the pink simulation material. And it sets up very fast. It'll set up in less than 3 minutes. So literally, by the time I get through injecting it around the abutment analogs and put everything down on the counter, I can go right over and pour my stone. it will set just like that. And you will wind up with a model, either you or the lab board, a soft tissue material around the analogs, which can be removed and replaced. So you've already done this, but we're simply removing the impression now. These trays are disposable, so they're one-time usage. It's a $3 impression tray. A custom tray will cost you $50 or more by the time you pay the lab or make it yourself. So this is economical and disposable. Removed it already, and you've probably taken a look at the interior. What you will find is a very good replication of the tissue size. You're ready now to insert the abutment analogs, or if you're not going to pour the bottle, obviously you ship it to the lab. They do it for you. You buy the analogs from the lab. You're not going to get around buying the analogs. It's just a matter of who does it. Here's your alternative. You can have an AVJ made that will provide you with the strut. Still long pins. You'll notice here that I cut that AVJ and reluted it before I made the impression. Because that AVJ was made off of the model from the conversion. And micro movement of the implants over 3 to 4 months can, and often will, allow the implants to move just a little bit. So my original model from the conversion certainly couldn't be trusted, could it? But it's still not a bad thing to do. You just put the AVJ on, find out if it passes the one screw test or not. Yep. And if not, cut it, lute it. I've luted it there with flowable composite. We talked about the one screw test. Here's an AVJ, and I built this specifically to show a misfit. So if you were in the mouth and you put one screw on the other side of this AVJ and saw that separation right there, that would be an incorrect model, and you'd have to correct the model. A little closer up, look. And when you push on it, you can see it move. Now, unfortunately, most of the time, it's not that clear cut in the mouth. And I certainly would do this with your loops on. One way to kind of check that is to see if you're seeing any percolation of saliva around the multi-unit abutment as you're pushing on it. And we looked at this earlier. Again, that's the way we do it in the mouth. Cut it if need be. So if we were using an AVJ, it would be the same technique, checking our tray over it, loading the tray with our heavy material, and then injecting a light viscosity over and under the AVJ. Same procedure though.
Looks like this material is so rigid, if somebody had undercuts on their ridge, it'd be pretty tough on
On the rigid material, it would be heavy. That's another good reason to go to heavy as opposed to rigid. And if it's bad enough, I'll block it out. But most of the time, that's not going to be the case. Yeah, but if you were going to scrape somebody, you'd do it with rigid, probably. Yeah. Okay, zip through that. Okay. Any questions? So I'm going to move on to a couple more cases. Steve and Kyle, I hate to hang on you guys, but could you all just start picking stuff up while I'm speaking? We'll leave the lights up. And just, if you want to just put them in boxes, we'll grab some other couple of guys to help. Because I'll need to start packing this stuff up while I head to the airport.
He's taken this.
It is important that I get everything back, including the pressure trace. I've got the components in there that I've got to dig out.
Hey, John. You know what? I need to ask one of these guys. I'm not sure. Let me ask one of these guys.
Thank you. painting, really are taking over. And I'll be packing things up in the back so that I can attend the airport. I'm happy to answer questions when I can. Let me just also point out, if I have time, I'm going to load John all these slides from today. But if I don't have time, I will load them and send them to John. Sooner or later, you'll get the slides. They will be in a PDF, John. Make sure they're in a PDF. Hey, John, make sure they're in a PDF when you send them out. Make sure they're in a PDF when you send them out. I'll do it. Okay, while we're getting settled back in, have your attention for just a couple of things before we finish up final cases. Let me just illustrate case presentation. Everybody has their own technique for presenting cases. I feel like I've really got it down. It's taken me a long time to understand that you only have a small segment of the patient's life to talk to them about their options. You got about 5 minutes for the patient to glean what you're telling them about. So I'm going to use models that you see up here when I'm presenting options to the patient. I'm going to use some videos that I have that illustrate my overdentures and all forward. Then I'm going to use my CBCT. And that will occupy about all the time that the patient can accommodate. I would suggest that you buy these two models. One, a representative of the all-on-4, and one of an overdenture. Now, through the years, I've accumulated dozens of models, and you will too. But it took me a long time to do that. Those models will cost you, demo models will probably cost you anywhere from $250 to $500 a model, depending on where you get them. Salvin has a lot of them, as well as Novell. But the two workhorses that I have are an overdenture model, demo model, and an all-on-4. Patients, there's not. I always want to tell the patient that it's not really a right or wrong, overdenture or all-on-4. You know, one suits some patients better than the other. But a lot of patients will look at these two models and look at the size difference between the all-on-4 and the overdenture, which is much bigger, and immediately gravitate to the all-on-4. The other very attractive feature, of course, to the all-on-4 is the patient walks out from day one with a stable appliance. It's a little more costly to do all-on-4, but it's not cheap to do an overdenture. So you also, over time, want to develop your pricing, if you want to put it that way, your fee determination for an all-in-4, an overdenture with 4 implants, an overdenture with 2 implants, an overdenture with 6 implants. You need to be able to spit that out before the patient walks out the door. That's a total reversal from the way I used to do things. In the 80s and 90s, I made the patient wait maybe 2 appointments to give them a final fee. You can't do that anymore. Society doesn't work that way anymore. That's the way I was taught to do it at Pankey Institute in Florida, but those days are over from that standpoint. So get yourself some demo models, something that you're comfortable with. Find there's scans of videos out there. YouTube, obviously. Avadent, the company itself, you will pay a fee, but they have a raft of videos, 1 minute or less videos, that put over the concept of an overdenture or an all-on-4. It gives that patient a great visual image. And so when I come in and start talking to them about the technicalities of it, they've already got that picture in their mind. I also want to use some little simple models. Salvin has these for bone loss, because that's a major concept that I have to get over to the patient. Okay, Mrs. Jones, after we take the teeth out, after a few years, and it's only a few years, we've lost a lot of bone. And then a few more years later, we've lost over half of the vertical height of your jawbone. And then down here, if you do nothing, you're going to wind up like this. I'm not saying it that way, I'm not threatening. But I want them to point out to the patient that without implants, that bone loss is predictable, it's going to happen, and it's not reversible. Whereas when we put in the implants, obviously, the bone loss stops. One more plug for Nobel, which is I buy Nobel Vision from Nobel. It's a direct feed into my reception room, and it points out those concepts very well also. Once you start doing a number of implant cases, whether you're doing it all yourself or you're working in conjunction with surgeons, but especially if you're working with multiple surgeons, it can get very confusing as to where all these cases are at any one point in time. Who's working with Dr. Shane? Who's working with Dr. Woodard? Where's that template for Dr. Tordrich? So we have to have a system for identifying where we are with all these cases, and we've come up with this. First of all, we have a typical file. Whenever we start, I mean from the beginning start, we open up a particular file card on that patient. We customize the card. You can do whatever you want to on it, but basically you want to be sure it's got if there's a referral or not, when the patient's going to have teeth extracted, when they're going to have a bone graft, when they're going to have implants placed. And when the implants are placed, what type and what size are they? What type of restoration are we envisioning having done? All that is at my front desk. So my 2 front desk people every week call every surgeon I'm working with and update their status with that patient. Then we'll take that information and put it on a calendar. We meet every morning in our sterilization room. Quarter late is the huddle. And one of the line items on the huddle is, what implant patients do we have coming up for the next 2 weeks? Actually, now it's for the next 2 months. Because today, in our practice, almost every day, we're working on an implant case of some sort. So on and this is, I just found an old slide. I've got it updated from this year, but every implant case is on that month. That calendar is dedicated just to implant patients. Anything in yellow is highlighted, means I've got to get something done. I've got to buy components, I've got to order them in, I've got to make an appliance, make a template, whatever. I've got to try in, I've got to have ready. It's in yellow until it's in the office or until it's taken to the surgeon's office, if that's where we're going to do. And when we get that task completed, we simply go over it in pink, it turns that orange, so from across the room, I can see, well, okay, I got everything done the first week in March, got a couple of things to do in the second week and a couple down the road. Whether it's your, that system or not, find a system where you can track what you're doing with your implant cases so you don't get caught short-handed. You don't have something over the surgeon's office when you're supposed to, or you don't have it in your office when you're supposed to. What if you're doing, an implant level impression, certain types of diameters of implants, and you don't have the right diameter implant compression coatings? And if that patient grows 2 hours, it's a bad day. So just get your system. So we like going from the tickler file to the implant calendar. We bring it all together at the morning time. My wife and I teach systems for building the implant practice, and that's just a little segment of that. Okay. Don't have enough time to go into all of that. Okay. How about instead of doing a 5-appointment procedure for all in 4, how about a 3-appointment procedure? Maybe even 2 if you're gutsy enough. I'm not gutsy enough yet. But 3 is pretty darn good. Now, this will require you to spend a little more time on the first appointment. And you'll do a little lab work. You'll pour bottles and mount bottles. So the trade-off is you spend a longer appointment time the first appointment, but you consolidate the first 2 appointments into 1 appointment. You get your impressions, your master impressions, and your jaw relation records all in 1 appointment. Then you move on for scanning and preview for milled technology. You might want to take a picture of that because talking through it gets a little confusing, or you'll get the slide. But I'll show you how we do this in the real arena. Basically, if you think about it now, the patient has been in, they're temporary all on 4s for 3 to 4 months, maybe longer. All the micro movement of the implants is shaken out by then, right? They're not going to move anymore. If that temporary all on 4 fits correctly, and meaning if the titanium cylinders bolting that temporary all on 4 in place, if they are solidly fitted to the multi-unit of buttons, that's the best strut system you'll ever have. There's no shakeout, there's no shrinkage to worry about. That's your strut. So if we make an impression and pick up the temporary all on 4 and structure that appointment so that we can get our case mounted and then give them back their temporary all on 4 that day, we've got a leg up on the numbers of appointments. So that's what we're going to do. Here's our patient. He's about a 70-year-old retired physician. Lots of wear, lots of recurrent decay, fractured teeth, lots of recession. All of those things